Hey y'all, it's Dr. Charlotte Hodges. I wanted to complete my series today on revision weight loss surgery. I've already talked about undergoing band revision, sleeve revision, and now I want to tie it up for my patients that have undergone older weight loss surgeries, whether you've had a previous open Roux-en-Y gastric bypass, previous laparoscopic gastric bypass, or even the old stomach stapling or vertical banded gastroplasty or VBG. You know, it's not uncommon for me to have patients that will come to see me that have undergone one of these surgeries 15, 20 years ago. And while initially they may have had some good weight loss, some resolution of their health problems like high blood pressure, diabetes, they're now coming to see me because they're just not losing the weight that they want, or weight has slowly begun to creep back in. And they're finding that just trying to undergo some medical weight loss options is just not getting them to the goals that they want. When I have a patient that comes to see me, if they've had a previous weight loss surgery, the first thing that I like to do is perform an outpatient procedure called an EGD. That is an upper endoscopy where I put a camera down their mouth and I look at their esophagus and stomach so I can get a good layout of the land. I can really see what their stomach anatomy looks like. I'm able to see how big was their original stomach pouch made. If they've had stomach stapling, is their lateral staple line, is that still intact? Has the band begun to erode or kind of work its way through the stomach wall? Performing this procedure is really going to give me a lot of good information on my patient's anatomy, and it really helps me with surgical planning, as well as giving the insurance companies information along with for them to undergo the approval process. So typically I have a patient that's coming to see me if they've undergone a previous gastric bypass, whether it was performed open or whether it was performed laparoscopically. What I like to do is revise them to kind of a form of a mix between a gastric bypass and duodenal switch. About 10 years ago when I first started doing these, what I would do is I would kind of put everything back together again, put the pouch back to the remnant stomach, put the small bowel together, and then I would actually go in and create a traditional duodenal switch where your stomach is a sleeve and you have a much more aggressive small bowel rearrangement compared with a gastric bypass. However, I was kind of finding that my patients were not having as many feelings of restriction as they did with their original surgery. And that's certainly part of a good successful surgery, having good adequate feelings of restriction. So now what I do in my practice is, if you've undergone a previous gastric bypass, what I like to do is go in, make your stomach a little bit smaller, and then give you the same small bowel rearrangement as a duodenal switch. So this is really what I would call a long limb gastric bypass. My patients do very well, and generally they'll lose about 70 to 75% of their excess body weight. And best of all, even if these surgeries were done open, I'm still able to perform these laparoscopically, and it's still just an overnight stay in the hospital. For my patients that have undergone stomach stapling or a VBG or a molinaband or any one of these older weight loss surgeries, generally these were all performed open. Again, these too can be revised to a new surgery. What I like to do is revise them to a gastric bypass or to a long limb bypass. What the studies have shown is that if somebody has a VBG or stomach stapling or molinaband, because of the amount of dissection or scar tissue removal that I need to do so I can get good healthy tissue, it's actually not very safe to perform a sleeve gastrectomy where I'm putting the two pieces of stomach together. Patients have many more issues with narrowing along the staple lines, ulceration, and reflux. So what my recommendation always is to revise these surgeries to a gastric bypass or to a long limb gastric bypass. Again, just like with someone that's undergone a previous open or laparoscopic gastric bypass, my goal with these older surgeries, give you a nice small stomach and give you a nice good small bowel rearrangement so that you can have good adequate weight loss. My patients are generally going to lose about 60 to 65% of their excess weight. That means you'll lose about 65 pounds for every 100 pounds that you're overweight. With all of my surgeries, whether they're revision or whether they're first-time surgery, you're going to have fairly low complication rates. Bleeding and infection happen about 5% of the time. Risk of leak, so that's risk of a staple line coming apart, that's less than 1%. Mortality is 0.05%. So these are going to be low-risk surgeries. Patients are able to stay in the hospital overnight, and they get to go home the following day. With all my surgeries, their patients are able to be off work maybe 1 to 3 weeks. I'm really not seeing a change in my patients in terms of them having longer recovery times if they're undergoing a larger surgery or a revision surgery, which I think is really good news for my patients. So if you're a patient that's undergone an old weight loss surgery, whether it's a gastric bypass or whether it's stomach stapling, or if you know someone that's been struggling with a former bariatric surgery and they're nervous about the thought of maybe undergoing another procedure, let them know that there's help out there. They can definitely get to their weight loss goals, and I'm here to help. I want to be able to help you every step of the way. So I really hope that this has given you guys some good information. If you'd like to give me a thumbs up, and don't forget to follow me. You guys take care.